Hello, welcome to our program, Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center. And I'd like to talk with you and share with you a case today that was quite interesting, somewhat perplexing and unusual for our clinical colleagues, and presents an interesting differential diagnosis and considerations. So let's begin and talk about this particular case. The patient is a 30 some odd young woman who had previously, in the past 3 months, had a surgical procedure to repair a laceration to her rectosigmoid colon. And following that, on a follow-up visit, she was found to have a mass lesion developing apparently at the site of the prior surgery. So the surgeons were concerned that that could be something of significance and began to investigate and to take a biopsy. But before we get to look at that, let's just consider what some of the concerns might be, any young adult such as this. Of course, neoplasms are possible. We don't usually think of them in this age group, but certainly patients can have polyposis syndromes, Lynch syndrome, other sorts of things that might present as a early onset malignancy. And then, of course, there are various mesenchymal lesions, GI stromal tumors, inflammatory myofibroblastic tumors, various other mesenchymal lesions, smooth muscle tumors, and so forth. And lymphoma should always be considered as a possibility as well. A number of infectious diseases can give you mass-like lesions, granulomatous disease, syphilis, and so forth. Inflammatory disorders also need to be considered, especially in patients who may have altered bowel habits. Solitary rectal ulcer syndrome or other prolapse syndromes are thought here. Other inflammatory diseases that might occasionally present might include things like leukoplakia and so forth. And then we have other diseases that are not really inflammatory or other sorts of things like endometriosis, foreign bodies that may get implanted and create a reaction, maybe post-pelvic floor surgery or something of that sort. And then various pseudoneoplasms, such as the postoperative spindle cell proliferation and things of that sort could be considered in this case as well. So here's the biopsy as we first perceived it, several small fragments, quite blue. As you can see at low magnification, there's just a lot of blue tissue. I don't see anything that looks like normal colorectal tissue in this field. And as we come into a higher magnification, we can see that indeed most of this is a dark blue inflammatory tissue. There do seem to be some epithelial elements here, but they're certainly not making goblet cells or mucin. And the epithelial component has a few cleared out cells, as you can see here, a few sort of nuclei sort of sitting in a clear space, variable amount of vascular tissue around. And as we looked at this on higher magnification, we saw that there was really quite a number of plasma cells in this stromal tissue component. We don't see ulcer debris per se. Here's a few vessels, a little bit less inflamed, and here you can see this sort of columnar type of epithelium with a little bit of a brush border, if you will, there, or at least a sort of fuzzy border. And again, no evidence of typical goblet or Paneth cells or anything of that sort. Looking at the other fragments, they seem to be quite similar. Again, very densely inflamed, bland columnar epithelium. So this is some sort of an inflammatory lesion, and it's certainly something that does not have the typical enteric type of epithelium. So other things that we considered here were that this was maybe taken from the wrong source. It could have been a specimen mix-up. We verified the label and the patient's name and identification and so forth. And then we began to say, well, what else could these things be? So what kind of epithelium this might be prompted us to do some differential cytokeratin staining. And in fact, this was CK7 positive, not CK20 positive. We also did PAX8, and lo and behold, this is PAX8 positive epithelium. And based on those two findings and the very inflamed stroma here, we concluded that this most likely was endometrial tissue type tissue, albeit tissue that's very densely inflamed and is distorted by this feature. So with that appraisal of what might the situation be, what causes this, why is this kind of tissue sitting here in this apparently prior surgical site? Well, if we think about ectopic endometrial tissue, it's actually quite frequent. In fact, as high as 10% of women of reproductive age may have ectopic endometrial tissue. And it's usually, as far as enteric involvement, it's usually mural. But occasionally it does extend up to and involve the mucosa. In terms of presentations, usually it's not in a postoperative state that you detect it. It's usually because they've had pain or a mass lesion, or they have some sort of constipation symptoms. They may have dyspareunia or infertility. And certainly if it involves the mucosa, as in this case, bleeding, cyclic bleeding, may be one of the presenting symptoms. In terms of risk factors for endometriosis, it's interesting that the duration and the early age of onset of menstruation seem to be associated with an increased likelihood of having this disorder present. And that may just be an increased number or frequency at which we have loose endometrial tissue circulating or mobile into areas where it might not otherwise normally occur. Sometimes there's a family history, and certainly altered structural changes, in other words, iatrogenic lesions or iatrogenic reasons can cause implantation of, or be associated with implantation of endometrial tissue. And finally, diet. This is an interesting study, but some epidemiologic data would indicate that diets that are high in meat and low in fruits and vegetables may be more prone to promote the spread of endometriosis. So just for comparison, let's take a look at other areas. Certainly one of the most frequent sites is involvement of the appendix. And in this case, it's just a very small area of serosal involvement. But we also see times when it's intraluminal and mural and may present as appendicitis in some sort of situations. Here's a side-by-side slide of a couple of mucosal involvement areas. You can see here we have sort of an ulceration sort of change. But note here we have a really nice associated endometrial type stroma. Almost looks a little bit neuroendocrine in some respects, but I think this becomes very recognizable as endometrial type tissue in contrast to here the adjacent colonic type tissue. So the epithelium looks different than this, and while we might originally think it could be neoplastic or something of that sort, once you see the stroma, that becomes very simple to identify it. And that was indeed one of the problems with our particular case, was that it was difficult to identify as endometriosis because it was so inflamed. Here is another example, again, one with a little tiny bit of surface involvement, where you see these more endometrioid type of epithelium here, contrasting with the goblet cells and so forth of the colonic mucosa, and some associated ulceration, granulation type tissue. Now, how is endometriosis managed? Well, most frequently, conservative therapy using some form of hormonal suppression can be used, either birth control pills, progestational agents, or other types of hormonal manipulation can be used as an effort to suppress the presence and spread of endometriosis, because it can become progressive and worse, primarily because there's no normal path for exodus of this deposit, and then hence they tend to slightly enlarge over time. Now, surgical extirpation has been associated with increased fertility, and if symptoms are serious and so forth, that may be what's required. Dietary change, as we've indicated, going to a more plant-based diet can certainly promote improvements in that regard. And then finally, you kind of enduring to the end, enduring to menopause, may be a helpful or maybe a feasible course, especially if someone's on the upper end of their fertile period. But that's not always possible. And sometimes endometriosis still continues to cause symptoms afterwards. So occasionally we get cases such as this where you've really got very extensive mural involvement as well as mucosal involvement here. There you see the possibilities here of mucosal involvement adjacent to the normal colonic mucosa, as well as very extensive intramural extension of this disorder here. Now I've included in with this slide a little bit of a poll if you want to just rethink what the sort of symptoms might be associated with this. It was mostly done for illustration purposes, but you're certainly welcome to answer that poll if you look up the slides, and then you can see what other people think might be the answer to that poll question. So several sites where it's coming to the surface, it's in the submucosa, and indeed extending all through the wall in this particular example. So our final diagnosis on our particular case for today is ectopic endometrial type tissue with a marked chronic inflammatory response. Is it endometriosis with chronic endometritis? I suppose you might conclude that that's a possibility. But in either way, it's certainly very inflamed. Well, I hope that this has been helpful, that you'll give us a thumbs up or like if you found it useful. And certainly, please share this if you have colleagues or friends wherever you're seeing this that you think might gain value from this brief program, please do so. And finally, we welcome your comments and hope that you'll subscribe to the channel so that you can catch future releases from our channel. And so until next time, thanks so much for joining me.